Radiologic technologists and ancillary staff who work with or near ionizing radiation face possible short and long-term effects of occupational radiation exposure. Further, radiologic technologists must minimize unnecessary exposure that risks the patient's safety while achieving the best possible image or outcome. This video reviews occupational dose limits, dose calculation, devices used to measure exposure, and safety best practices that can help technologists keep radiation exposure as low as reasonably achievable for them and their patients. The video also discusses the appropriate use of fixed and mobile equipment, protective equipment, and safety features on imaging equipment to minimize unnecessary radiation exposure. After viewing this presentation, you should be able to list the basic principles of radiation production, describe dose limits and measurement, explain safety measures including inherent protection and protective devices, identify safety best practices for radiologic technologists, discuss the risks of radiation exposure.
For the radiologic technologist, medical imaging often is a balancing act. What combination of milliamperage and kilovoltage is needed to ensure the best image? When should the patient wear lead shielding? And how can unnecessary anatomy be excluded to save the patient from unnecessary exposure? Occupational radiation safety is also a concern because a high cumulative dose of radiation can be dangerous. Currently, the National Council on Radiation Protection and Measurements, the NCRP, has 124 reports regarding radiation safety for public and occupational sectors, including recommendations for dose limits. The United States Nuclear Regulatory Commission, the NRC, has adopted those limits and, in conjunction with state and federal laws, mandates construction specifications of exam rooms and adjacent areas, and dose monitoring procedures to protect those who work with radiation. There have been many advances in radiation protection theories and practices since X-rays were first discovered. Although William Rankine is credited with discovering the properties of X-rays in 1895, he was not the only scientist working with radiation. Thomas Edison realized the potential of X-rays and constructed his first fluoroscope in 1896. Over the course of a few years, his lab assistant, Clarence Daly, was exposed to enough radiation to cause severe burns, which led to the amputation of his fingers and arms, and finally to his death in 1904. Daly's death was the first recorded fatality in the United States caused by the cumulative radiation exposure from X-rays, just 9 years after they were first discovered. Dr. William Rollins, a dentist in Boston, used X-rays in his practice and experienced a radiation burn on his hand, which led to experiments with radiation on guinea pigs. In 1901, Rollins published a paper cautioning against using X-rays without some type of lead shielding for the tube, patient, and radiographer. In 1915, the British Rankine Society took Rollins' advice and made the first formal advances to protect patients and medical radiation workers by adopting a resolution recommending that X-ray tubes be shielded. In 1934, the U.S. Advisory Committee on X-ray and Radium Protection, now known as the NCRP, issued the first report of recommended maximum exposures. NCRP Report 116, published in 1993, set the current public and occupational dose limits for exposure to ionizing radiation. ALERA, or as low as reasonably achievable, is the principle used today to help manage both patient and occupational radiation exposure. To help radiologic technologists adhere to the ALERA principle, the American Society of Radiologic Technologists maintains a radiography program curriculum that focuses on radiation production and safety. The ASRT published its first recommended radiography curriculum in 1952 and has continually modified it to keep up with advances in knowledge and technology. The current curriculum includes an introduction to radiologic science and healthcare, radiation production and characteristics, radiation biology, and radiation protection.
Radiation is the act of emitting energy in the form of photons or particles. It is considered ionizing when the energy can produce changes in atomic structure by creating positively or negatively charged atoms. The types of ionizing radiation used in a diagnostic imaging department are X-rays, gamma rays, and beta particles. The nature of the images sought determines the type of radiation used. When most people picture an atom, they think of the structure described by Niels Bohr in 1913, a dense nucleus housing protons and neutrons, surrounded by electrons moving in elliptical paths. These ellipses are called shells. The shell closest to the nucleus is the K shell, with successive shells L through Q available depending upon the element. Each shell has a predetermined maximum number of electrons. In a stable atom, there are enough shells containing negatively charged electrons to balance out the number of positively charged protons in the nucleus. A neutron has no charge. Electrons are held within their orbit by binding energy. Ionizing radiation is any radiation capable of overcoming the binding energy and knocking an electron from its shell. Radiology modalities use different types of ionizing radiation. X-rays are created when an outside source bombards a target with an artificially created stream of electrons. The transfer of energy from the electron stream to the innermost electrons of the target's atoms creates X-ray photons with characteristics that identify the target material used. The resulting photons are known as characteristic X-ray photons. However, if the electron stream interacts with the nucleus of a target atom instead of the electrons, it produces bremsstrahlung radiation. A bremsstrahlung photon is created when an electron from the stream passes close enough to the target nucleus to be affected by its electrical field, or when it collides with the nucleus. Either interaction will result in a loss of energy by the incoming electron. This loss of energy becomes the new X-ray photon. Nuclear medicine uses beta particles and gamma rays rather than X-rays. A beta particle is created when an unstable isotope with too many neutrons emits an electron from its nucleus in an attempt to reach a state of stability. Gamma rays carry the same properties as X-rays, including ionization. However, they originate from the nucleus of an atom after an electron or a positron is emitted from it. The creation of both gamma rays and beta particles is considered radioactive decay or disintegration. The X-ray tube used in diagnostic radiography consists of a negatively charged cathode that emits a high-powered stream of electrons towards a rotating positively charged anode. The electrons react with the atoms of the anode, creating X-ray photons that are directed through a glass window towards the subject to be imaged. The original stream of photons produced is called the incident X-ray or primary beam. Within the diagnostic radiography range of kilovolts, X-ray photons can interact with human tissue in three ways: coherent scattering, Compton effect, photoelectric effect. Coherent scatter, also called Thomson, classical, or unmodified scatter, results when a low-energy incident photon causes tissue atoms to vibrate. An atom may absorb the incident photon and then expel a scattered photon with a change in direction, but no change in energy. The scattered X-ray at such low kVp does not change the composition of the tissue atoms, so it is not considered ionizing radiation. Coherent scatter does not increase patient or technologist dose and does not provide any useful diagnostic information, but it can cause fogging on an image receptor. Scatter radiation produced by the Compton effect presents the greatest danger to technologists. The Compton effect occurs when an incident photon interacts with an outer shell electron from the patient or other human tissue and knocks it from its orbit. The result is a scattered X-ray and a Compton electron, with a combined energy equaling that of the incident photon. Either one can also interact with more tissue. The Compton effect could happen with any X-ray photon, but it is more likely to occur as the energy of the incident photon increases.
The scatter produced by the Compton effect is considered isotropic, meaning it can travel in any direction from its point of origin. For example, if a patient is positioned for a posterior-anterior chest radiograph, a Compton pair may scatter forward, backward, to the side. Technologists can avoid Compton effect scatter from a single radiograph if they are in the control booth with shielding or stand at a sufficient distance from the potentially dangerous scatter. However, large amounts of scatter produced by patients during fluoroscopy can greatly contribute to occupational radiation dose.
The photoelectric effect occurs when an incident photon interacts with an inner shell electron, such as the K shell. The photon knocks the electron from its orbit and releases all of its energy. The new photoelectron has energy equal to the incident photon minus the binding energy of the original electron. The binding energy of the K shell of human tissue is relatively low. Therefore, the photoelectron created during the photoelectric effect can continue to interact with other atoms within the patient, causing an increase in patient dose. Radiation exposure is measured in a variety of ways depending on the nature of the radiation and the reason behind the measurement. Two different units are used to describe radiation, either conventional British units or the International System of Units, commonly known as SI units. In diagnostic radiography and computed tomography, the conventional unit of measurement of radiation intensity is the Roentgen, or Coulomb per kilogram. This measurement represents the amount of radiation produced before it interacts with an object and is based upon the potential damage of any particular dose of radiation to human tissue. The radiation intensity of diagnostic X-rays is generally measured in milliroentgens. Within the diagnostic department, patient dose is measured in radiation absorbed dose, or grays, and occupational exposure is measured in radiation equivalent man, or sieverts. Radiation absorbed dose reflects the amount of radiation a person or body part absorbs as the X-ray photon passes through the body. The REM is based on the expected biological effect of a specific type of radiation exposure. Within the diagnostic radiography spectrum, 1 Roentgen equals 1 rad equals 1 REM. However, as we will see, this is not always true for all types of radiation. An isotope is an atom that has the same number of protons and electrons as commonly occurring elements, but differs in the number of neutrons. For some isotopes, this change in neutrons makes them unstable and different processes occur to correct this instability. Disintegration describes the process that occurs when the nucleus of an unstable isotope emits a particle in an attempt to reach stability. Radioactive isotopes, such as those used in nuclear medicine, are measured using the Curie or Becquerel. The Curie and Becquerel are measurements of the quantity of material, not necessarily a measurement of radioactivity produced. The potential damage of any type of ionizing radiation on human tissue is expressed as relative biological effectiveness and is measured using the REM or the sievert. Diagnostic X-rays, gamma rays, and beta particles are each assigned an RBE of 1. Larger and more damaging particles, like alpha particles, are assigned a higher RBE of 20.
The NRC mandates that all workers who are routinely exposed to radiation be monitored so that they do not exceed the annual dose limits set forth by the NCRP. The most common way to measure occupational exposure in a radiology department is through personal dosimeters, such as a film badge, thermoluminescent dosimeters, or an optically stimulated luminescent whole-body dosimeter. A typical film badge is a small piece of plastic that contains metal filters and film. The filters interact with radiation received by the wearer and leave an impression on the film. Film badges are a reliable way to track dose for all types of radiation used in a hospital setting and begin detecting radiation exposure at 10 MR and higher. They are relatively inexpensive, but inadvertent exposure to humidity or temperature can damage the film. A TLD is similar in size and shape to a film badge, but works in an entirely different way. Instead of film, a TLD uses a lithium fluoride crystal that reacts with radiation by exciting electrons and keeping them within a framework. When heated, the electrons drop from their frame and emit light. This light is then measured to estimate the amount of radiation exposure. TLDs are more sensitive and more accurate than film badges, down to 5 MR, but they can cost up to twice as much as film badges. An OSL dosimeter is similar in function to a TLD, with the exception that, when read, the crystals within are stimulated by the light of a laser instead of by heat. The technologist is responsible for wearing his or her dosimeter in the proper place at all times during work hours, and only when working. Any dose absorbed outside of work is considered non-occupational radiation and should not be included in occupational monitoring. Badges should be worn at waist or chest level under normal circumstances. If the technologist is wearing a lead apron, he or she should wear the badge at neck level to get an accurate reading for exposed anatomy, such as the eyes. There are also extremity dosimeters, or ring badges, that generally are worn by nuclear medicine technologists because their hands may be subjected to direct radiation exposure. Film badges, or TLDs, are collected monthly or quarterly by one designated person within the radiology department, usually the radiation safety officer or quality manager. The dosimeters are sent to an outside company that processes them and prepares a report for the radiation safety officer. Per NRC regulations, all employees are allowed to see their reports. If there are any suspicious spikes in radiation, The radiation safety officer will try to determine a specific cause and provide counseling to the employee. Pregnant technologists should wear a second dosimeter at waist level. When wearing lead, the technologist should place the abdominal dosimeter under the shield. This is called a fetal dosimeter or fetal monitor. A pregnant radiologic technologist is under no federal obligation to report her pregnancy to her manager, but full disclosure will make it easier to avoid any unnecessary exposure. Not exceeding the radiation dose limit for an embryo or fetus is easily achieved by following the time, distance, and shielding rules. A pregnant technologist should wear a wraparound lead apron or skirt and vest when assisting during fluoroscopy. The dosimeter should once again be worn at waist level and beneath any lead shielding the technologist wears. Any questions regarding possible exposure to the fetus should be referred to the facility's radiation physicist or radiation safety officer.
Occupational dosimetry is mandated by the NRC to keep radiation exposure within the limits recommended by NCRP Report 116. The general public is limited to a yearly whole-body dose of 500 millirem, or 5 millisievert. Radiation workers are allowed 10 times more radiation for total body dose of 5,000 millirem, or 50 millisievert. However, there is also a cumulative occupational dose limit in effect of 1,000 millirem, or 10 millisieverts, times age in years. For example, if a radiologic technologist is 35 years old, his or her total exposure should not be more than 35,000 millirem, or 350 millisievert. The radiation safety officer must make available a cumulative occupational dose history form if requested by a technologist. Yearly dose limits for specific body parts are based on their radiosensitivity and susceptibility to damage from ionizing radiation. These limits are based on the work of two scientists who described this phenomenon. The law of Bourgondier and Tribondeau states that radiosensitivity of a cell is determined by 4 factors: differentiation, age, activity rate, and rate of mitosis. Stem cells, younger cells, very active cells, and rapidly dividing cells are more radiosensitive than differentiated, older, dormant, or dead cells. The dose limits for adults who work in any field containing a regular, continuous chance of exposure to radiation are 15 rem, 0.15 sievert to the lens of the eye, and 50 rem, 0.5 sievert to the extremities or skin of the entire body. Embryo exposure is not differentiated between radiation workers and the general public. The total gestational dose is 500 millirem, or 5 millisievert. Dose limit for each month of the pregnancy is 50 millirem, or 0.5 millisievert. The U.S. Department of Energy maintains a chart of dose comparisons compiled from research by Noel Medding that puts these doses into perspective. According to the chart, a chest radiograph delivers a dose of approximately 10 millirem to 20 millirem, and a dental exam delivers 160 millirem. Natural background radiation in the United States is listed at 300 millirem, and the typical airliner crew is exposed to an average yearly dose of 200 millirem to 400 millirem out of the yearly 1,000 millirem limit.
When discussing the deleterious effects of radiation, the accepted theory is a linear non-threshold model. The higher the radiation exposure, the more damage it can produce. When using this model, any dose of radiation can be harmful. Generally, potential effects of radiation are discussed in terms of acute versus chronic exposure and whole body versus localized exposure.
Severe effects of radiation exposure can manifest for either a specific body part or system or for the entire body. No damage occurring below a dose of 5 rad has been documented. For acute exposure, the smaller the area exposed, the more radiation is needed to cause measurable damage. Whole-body radiation exposure of 5 rad or more can cause chromosomal changes, whereas 10 rad are needed to affect gonadal function. Reddening of the skin, called erythema, can occur in a small area exposed to 200 rad, and hair loss, known as epilation, to a comparatively sized area can occur at 300 rad. The entire body can be exposed to lower doses with localized effect, but if left untreated, a whole-body exposure of 600 rad or more will result in death. The severity of the effects of acute radiation exposure follows a documented pattern of symptoms based upon the dose received. The prodromal period, directly after exposure of 100 rad or more, is characterized by nausea, vomiting, and diarrhea. This period may be followed by a latent period in which the exposed person does not show any outward symptoms. If the dose received is between 200 rad and 1000 rad, manifest illness begins with a return of the nausea, vomiting, and diarrhea and includes cell count changes in the blood. Exposures of 1000 rad to 5000 rad lead to lethargy and shock, followed by symptoms of damage to the central nervous system at exposures greater than 5000 rad. The progression of exposure to death can take anywhere from approximately 3 to 60 days, depending upon the whole body dose. Atomic bomb survivors are a unique population that scientists continue to observe to determine the effects of short-term exposure over an extended period of time. The Radiation Effects Research Foundation is a cooperative effort between Japan and the United States to track statistical evidence of cancer and other diseases in the survivor population. According to the Radiation Effects Research Foundation, incidence of radiation-induced cancer coincides with the age at exposure and the time elapsed since exposure. Statistics indicate that the younger the age at exposure, the higher the incidence of cancer, which follows the law of Bourgondier and Tribondeau. However, for those victims who lived more than 20 years past the bomb, risk of leukemia became equal to that of the non-irradiated population.
Chronic exposure to ionizing radiation, even at low doses, has been shown to lead to several health conditions. Cataracts, leukemia, and several types of cancer have been linked to radiation exposure in certain populations, including radiation physicists and early radiologists who practiced before modern safeguards were in use. Clusters of thyroid, bone, and breast cancers have been attributed to the overzealous use of radiation treatment for health conditions in the past. It's an unfortunate truth that some patients are over-radiated in the name of diagnostic imaging. Although the benefits generally far outweigh the risks, there are documented cases of patients suffering erythema, epilation, or worse because of fluoroscopy or similar imaging procedures. The National Institutes of Health is conducting research on the risks of developing cancer from occupational radiation. With the exception of a possible but still unproven link to breast cancer, modern radiologic technologists are at no greater risk for cancer than non-radiation workers. However, following radiation safety guidelines is crucial. As a working technologist, you have several ways to protect yourself from radiation exposure, such as limiting your time in a room where ionizing radiation is being used, increasing your distance from a radiation-producing source, and personal protective equipment. The inherent protection provided in equipment construction and workplace design is also designed to protect you. Probably the most powerful tool for you to use to protect yourself and your patient is your understanding of the nature of radiation. The construction of diagnostic imaging equipment includes several elements designed to help keep a technologist's annual dose under the 5,000 millirem or 50 millisievert limit set by the NRC. The housing of an X-ray tube must be sufficient to absorb any radiation not included in the primary beam, so the leakage from the housing at a distance of 1 meter does not exceed 100 millirads per hour or 1 milligray per hour. If the initial construction materials aren't sufficient, extra filtration can be added. The entire filtration for an X-ray tube above 70 kVp, which most multi-purpose tubes are, must be equivalent to 2.5 millimeters of aluminum. The X-ray tube also has a set of collimators or shutters, which not only helps direct the primary beam, but absorbs any radiation not focused on the patient. Radiation protection is built into any room designated for use with radiation equipment. Two types of barriers, primary and secondary, coincide with protection from either the primary beam or secondary scatter. The primary beam is the photon energy directed from the X-ray tube through a patient to an image receptor. The primary beam is given the most consideration because it contains the highest amount of radiation. Any wall, including ceilings and floors, perpendicular to the path of the X-ray beam must have at least an equivalent filtration of 1/16 inch of lead. This is considered a primary barrier. Secondary barriers are used to protect technologists and other personnel from scattered radiation coming from the tube, the beam, or the patient. Secondary barriers can be half that of a primary barrier or the equivalent of 1/32 inches of lead. Both primary and secondary barriers can be constructed of any material as long as the thickness used provides the needed protection. Several factors are considered when engineers decide how much protection is built into a particular room. The workload factor relates to how often the room is used for radiation work and general kilovolt levels used. The occupancy factor refers to the use of rooms adjacent to the radiation workspace, who is using them, such as radiation workers, non-radiation workers, or the public, and the possibility of exposure. The calculations for these and recommended construction information are included in reports 49 and 102 from the NCRP.
Radiologic technologists don't have to think about inherent protection because it is a built-in safety feature in all radiology departments. However, technologists can take steps to further protect themselves from primary and secondary radiation.
One method of protection is a mobile shield, which is a vertical piece of plexiglass or metal on wheels. It can be positioned so that a technologist or other personnel can step behind it during a fluoroscopic procedure or radiographic exposure when a lead apron isn't available or practical. These devices should contain between 0.5 millimeter and 1 millimeter of lead equivalent to absorb scatter radiation sufficiently. Mobile shields are particularly useful in the operating room when one diagnostic image is being taken, but they aren't very practical for use with the C-arm. The term lead shield can be misleading because many shields are no longer made of lead, but instead use a lighter weight composite of other metals such as tungsten or tin at a thickness that's equivalent to the properties of lead. Lead shields come in different shapes and sizes to protect certain body parts. The most frequently used apron is the body apron, which must be at least a lead equivalent of 0.25 millimeters. The apron is used to protect the bulk of the chest area down through the gonads on the anterior side. Aprons generally have Velcro straps that are used to secure the sides, but some have wraparound straps that place less stress on the shoulders and back. Because aprons only protect a wearer from the front, a technologist should never turn his or her back to the primary beam or the patient who may emit scatter. This same lead equivalent applies to vest and skirt shielding, which can be used during fluoroscopy. This pairing provides full protection from the chest to the gonads for the front, back, and to the sides. Compared with an apron alone, the extra protection of the vest-skirt combination increases the weight of shielding and might be a consideration for the technologists. Because of the one-size-fits-all approach, lead aprons and vests may fit loosely and generally don't fully protect the thyroid, which is a butterfly-shaped gland that sits above the sternal notch in this area. This gland is sensitive to radiation and should be shielded whenever possible with a thyroid shield of 0.5 millimeter lead equivalent or greater. A thyroid shield is fairly lightweight, wraps around the neck, and is secured to the back with Velcro. Although the radiologic technologist should avoid intersecting the primary beam if possible, sometimes it's unavoidable, especially during fluoroscopy. During upper GI exams, for example, a technologist may need to help patients turn over or hand them barium to drink during the test. In these cases, the technologist should wear lead-lined gloves to protect his or her hands and wrists. These gloves must have at least a 0.25 millimeter lead equivalent. Additionally, protective eyewear should be worn during lengthy fluoroscopic procedures. Slightly heavier than regular glasses, protective eyeglasses should have side panels of leaded glass and must have 0.5 millimeter of lead equivalent. Technologists can reduce their exposure to 1/4 of the original dose by doubling their distance from the source. For example, if a technologist stands 1 foot from a source of radiation where the intensity is 10 MR, and then moves back another foot from the source, the inverse square law tells us that the intensity of radiation will be reduced to 1/4 its original reading. So doubling your distance from a radiation source will reduce your exposure to 1/4, or in this case, 2.5 MR.
Time, shielding, and distance are cardinal rules of radiation protection. Understandably, limiting exposure time helps minimize dose, and shielding protects the technologist from low-dose scatter radiation. However, maintaining distance from the source of the scatter is the easiest way for technologists to protect themselves.
During their initial education, radiologic technologists are taught that time, distance, and shielding are the best ways to protect themselves from radiation exposure and adhere to the ALARA principle. If technologists spend as little time as possible near radiation, stand as far as possible from the source, and use their shielding, their occupational dose should stay relatively low. However, special considerations should be taken into account depending upon the modality. Modern radiography departments may use computed radiography, digital radiography, film cassettes, or a combination of all three. Regardless of how the image is captured, the radiation used for any type of radiography is the same. Although the chosen imaging method may affect patient dose, the same types of protection apply for radiologic technologists regardless of the imaging method. The control booth is a safe area behind secondary barriers. If the construction of the room is up to code, the radiation in this area will be held to a maximum of 100 millirem or 1 millisievert per week. The control panel for the X-ray tube contains exposure controls and an exposure button that can be connected by a cord so that the technologist can hold it in his or her hand. The cord should not be long enough to allow the technologist to enter the imaging room while making an exposure. For the safety of both the technologist and the patient, there should be a leaded glass window that allows the technologist to watch the patient without being exposed to radiation. Basic radiography rooms are used for many types of examinations, and generally the X-ray tube can be pointed in any direction. The technologist is responsible for ensuring the tube is never pointed at an open doorway, the control booth wall or window, or anything other than the image receptor. Also, focusing the beam collimators and using the smallest field of view necessary ensures that the patient and technologist are exposed to the least amount of radiation possible. If a patient does need help remaining still during an exam, patient restraint devices can be used instead of having a staff member hold the patient in place. Some exam tables have safety straps, and wall units have stabilization bars. Most diagnostic radiography departments also have sandbags that can be used for several purposes, including weighing down patients' arms for a cervical spine study, securing a pole that the patient is holding for stabilization, and keeping an extremity in a particular position. Adhesive tape should only be used as a last resort to keep a patient or body part still, and only if the patient gives consent. If personal assistance is necessary, a member of the patient's family should be the first choice to remain in the room with the patient during an exam, provided that that relative is not pregnant and does not suspect that she may be. If a member of the family isn't available, a hospital employee who generally is not exposed to occupational radiation, such as a nurse, can help. Radiologic technologists should be the last choice to help a patient stay still during an examination. Finally, whoever remains with the patient in the exam room for this purpose, hospital staff member or not, should be advised of possible radiation exposure and should be given a minimum of a lead apron with a thyroid shield and leaded eyewear if needed. If a patient is not able to come to the imaging department, basic radiographs can be taken using portable radiography equipment. The technical factors used in portable imaging may be slightly lower than a fixed machine, but the technologist generally doesn't have an opportunity to leave the room and take the exposure remotely. To ensure the technologist's safety, the cord to the exposure button on a portable machine must be at least 6 feet long. Each portable X-ray machine should have a hook or storage place for a lead apron, which technologists should wear when performing portable exams. Additionally, the technologist should stand at least 6 feet away from the patient and at a 90-degree angle from the primary beam, where there is the least amount of scatter. Fluoroscopic units are located in diagnostic imaging departments and are typically used for studies involving ingested or inserted barium, or for needle placement such as a myelogram. The table can be positioned horizontally so that the patient lies prone or supine, or it can be tilted vertically to allow the patient to be examined in an upright position. Whereas radiography is static, fluoroscopy is more dynamic because it uses X-rays to show real-time images during a procedure. A general fluoroscopic study uses the same X-rays as a regular tube, but it involves a continuous projection of the primary beam instead of one exposure. Fluoroscopy equipment has built-in protection. Traditionally, the X-ray tube is located within the table. Although some models may have the X-ray tube over the table, both types have the requisite housing to prevent radiation leakage. If the tube is located within the table, the tower is situated above the patient or in front of the patient if the table is positioned vertically, and contains the image intensifier or the receptor. Considered a primary barrier, the tower requires at least 2 millimeters of lead equivalent shielding. The table contains a bucky tray to hold a cassette for a single image. When the fluoroscopy unit is used, The tray is moved to the patient's feet so that the opening in the side of the table is shielded by the tray's slot cover, which contains at least 0.25 millimeters of lead equivalent. A curtain of at least 0.25 millimeters lead equivalent should be connected to the tower when the table is positioned horizontally. If the X-ray tube is above the patient, then corresponding safety precautions should be taken to satisfy recommendations made in NCRP Report number 102. During fluoroscopic procedures, a radiologist, a technologist, and occasionally other personnel are in the exam room with the patient. It is especially important for all personnel to adhere to the rules of time, distance, and shielding during fluoroscopy. The pedal, pulse mode, and timer can help with limiting the exposure time. The main exposure button for fluoroscopy is a foot pedal, which may be a rounded piece of rubber that lies flat on the floor, or a metal pedal. The foot pedal is attached to the fluoroscopy unit by a long cord and is generally positioned so the radiologist can stand on the pedal while manipulating the fluoroscopy tower. The pedal is called a dead man switch because the beam will stop if pressure on the pedal is removed for any reason. There also will be an exposure button on the tower or the table console of the fluoroscope that the radiologist may prefer to use, and it must be continuously pushed. The fluoroscopic tube also has the option for a pulsed beam for fewer frames per second. For general fluoroscopy work, this will not interfere significantly with the diagnostic quality of the test. However, it will reduce patient dose and scatter production as a result. Fluoroscopy units are equipped with timers that will sound an alarm after 5 minutes of fluoroscopy time, forcing the technologist or radiologist to acknowledge the cumulative exposure time and silence the alarm. Even before the alarm sounds, it is within the scope of practice for the technologist to remind the radiologist of exposure time for the safety of everyone in the room. Alarms will continue to sound at each 5-minute interval of fluoroscopy time. Keeping a sufficient distance from primary and secondary sources of radiation during fluoroscopy can be a challenge. The technologist is often called upon to help move the patient or manipulate equipment during an exam. According to the inverse square law, the technologist should stand as far away from the patient as possible while still being able to perform his or her duties. Shielding is essential for technologists and any other personnel present during fluoroscopy procedures. Often technologists must stand near the primary beam and the patient, whose body generates scatter, to assist the radiologist with the exam. Personnel should wear a full lead vest and skirt, thyroid shield, and leaded glasses. If vests and skirts are not available, technologists should wear aprons and pay special attention not to turn their backs toward the primary beam or the patient, because the physician could initiate the primary beam at any time. Although lead gloves may not be practical for tasks that require dexterity, they should be worn if technologists' hands might make contact with the primary beam or the patient. Several routine procedures in the operating room require a radiologic technologist's assistance. Plain radiographs often are used to check the location of a needle in spinal surgery or to perform a quick cholangiogram after stent placement. The biggest adjustment when using a portable machine in the OR is beam intensity. Because of the sterile surgical site and surrounding area, the intensity of the beam may need to be increased or decreased to compensate for changes in source-to-image distance or object-to-image distance. The technologist should always use a mobile shield or wear a lead apron and extend the full length of the 6-foot cord on the exposure button to ensure the lowest occupational dose. Similar to a portable fluoroscopy machine, a mobile C-arm also is used in the OR. It is shaped like a C with the X-ray tube mounted on the bottom curve and the image intensifier or receptor on the top curve. This unit can be useful in the OR for both static and real-time imaging of fixation screws, pacemaker lead placement, or angiographic work. A C-arm can be draped for sterility and moved over and under the patient rather than moving the patient themselves. The challenge for the technologist is keeping track of the X-ray tube and therefore the direction of the primary beam, as its mobility means it can irradiate the patient and surrounding personnel from almost any direction. A C-arm generally has 2 basic exposure buttons. One on a cord or remote that's similar to a portable X-ray machine, and one is a foot pedal that may be by itself or included in a panel of several different pedals. C-arms generally have the same capabilities as fixed fluoroscopic equipment and can be operated in pulse or angiographic mode using other pedals on the foot panel.
When in an OR with a C-arm, the technologist is within his or her scope of practice to remind the physician or other personnel of radiation safety guidelines and to ensure his or her own safety by wearing wraparound lead and a thyroid shield. Modern helical or spiral CT units are constructed using slip ring technology that allows the X-ray tube to rotate 360 degrees around the patient as the table moves through the gantry. A helical unit can complete an entire dynamic study in less than 1 minute, but the primary beam is on the entire time. Because of the continuous exposure of the beam, patient dose in CT can be significantly higher than in radiography. For occupational dose, however, it is generally the opposite. Most CT technologists receive little or no radiation exposure because they are usually behind the secondary barrier of the control room wall while the beam is on. Helical units are used for special procedures performed by a radiologist or other physician using the guidance of CT images to place a needle for tissue biopsy or a drainage tube for an abscess. All units can image the same 20 millimeters of tissue at given intervals to check for needle placement. Some CT units are also capable of fluoroscopy, which can reduce the length of the procedure because it provides real-time imaging. However, CT fluoroscopy also can raise the patient's exposure if the radiologist or other physician does not use the fluoroscopy pedal carefully. As in radiography, raising patient exposure produces a greater amount of scatter, which increases occupational exposure for technologists and other personnel who may be assisting in the exam room. Wraparound lead and thyroid shields should be worn, with leaded glasses if needed, by any technologist or other personnel who must assist the patient during the exam. Interventional radiology is performed by specialized radiologists using invasive procedures under fluoroscopic guidance for diagnostic or therapeutic purposes. The equipment used in interventional radiology looks similar to a C-arm used in the OR, and although it differs in some aspects to regular diagnostic equipment, the X-ray beam and resultant scatter are the same. Interventional radiology procedures generally require more time, up to several hours more, than fluoroscopy procedures conducted in the diagnostic radiology department. Because of the length of time the technologist is exposed to the beam, working in the interventional radiology suite generally carries the greatest risk of occupational radiation exposure, up to 15 times more than general radiography. To minimize their exposure, technologists should follow all shielding guidelines, and they should also be rotated between the exam room and the control room. Radiation safety in radiation therapy is quite different from radiation protection in radiography, CT, or fluoroscopy. For treatment procedures that use live radioactive sources, the fundamental concepts of time, distance, and shielding apply. But because of the very powerful X-rays used in therapeutic applications, it is not practical for a radiation therapist to spend any amount of time in the treatment room or to try to increase their distance from the source. Shielding is the only effective way for radiation therapists to protect themselves. A therapist must leave the room during the treatment and rely on the shielding built into the structure of the treatment room for protection. Depending on the strength of the X-ray beam being used, the thickness of the walls of a radiation therapy treatment room often exceed 3 feet of solid concrete. The thickness of the wall can be reduced if materials of higher density are used, such as lead. All members of a diagnostic radiology department may be called upon to assist with transferring a patient to an exam table or transporting a patient between modalities. Therefore, all technologists should understand the differences in radiation safety requirements between radiography and nuclear medicine. The machinery used in nuclear medicine does not emit radiation and poses no risk to the patient or technologist. Any risk of exposure to a nuclear medicine technologist comes from radiopharmaceuticals, which are radioactive isotopes combined with particular drugs to pinpoint the body part of interest. Exposure can happen either before or after the radiopharmaceuticals are administered to a patient. Radioactive isotopes are stored in special containers in a clearly marked room per NRC standards. The dosage of any particular isotope is based on its half-life or the amount of time it will take for the radioactivity to be halved. Once the correct patient dose, measured in millicuries, is calculated, the nuclear medicine technologist administers the radiopharmaceutical to the patient while following established department protocol. The radiopharmaceuticals travel through the patient's body where it is either diffused or concentrated in a particular organ or disease process, depending on the tagging characteristic of the radiopharmaceutical used for that test. The patient emits gamma rays and beta particles that are used to produce the diagnostic image and can be a source of radiation exposure for others. Transport of the radiopharmaceutical to the patient also depends on the nature of the test. If a technologist needs to leave the nuclear medicine department to inject a patient, the syringe containing the isotope is transported in a lead-lined box. The syringe may also have a lead-equivalent shield to protect the hands of the nuclear medicine technologist. No one other than a technologist should handle the box or the syringe. Once the isotope is administered to the patient, the wait before the actual nuclear medicine test begins can be anywhere from 30 minutes to an entire day. Patients, and caregivers if present, receive explicit instructions regarding radiation safety if there is any danger of radiation exposure to others. Although there are some isotopes used in medical imaging that may take days to completely decay, most do so within a few hours to a day. Generally, patient radiation exposure from a nuclear medicine test is equivalent to that of other modalities in diagnostic radiology. As with other modalities, time, distance, and shielding are the best way for nuclear medicine technologists to avoid radiation exposure from a patient injected with a radioactive isotope. 1 hour after injection of a radioactive isotope, exposure rates at a 1 meter distance from the patient vary from 0.54 millirem to 1.5 millirem. A notable exception is any test that uses iodine-131, which can have a rate of up to 45 millirem per hour, depending on the dose. However, NRC regulations state that patients given radioactive iodine only may be released from isolation if they emit less than 5 millirem per hour at a distance of 1 meter. The nuclear medicine technologist is charged with keeping personnel aware of any danger from patient exposure.
It has been more than 100 years since Wilhelm Röntgen discovered most of the properties of X-rays. As medical imaging has advanced, so has the need to stay up to date on the protection standards that keep our patients and ourselves safe in the medical imaging department. Educating everyone involved in medical imaging on the basics of radiation production, the damage potential for human tissue, and the ways in which they can protect themselves are minimum standards that should be enforced in diagnostic imaging departments. Radiologic technologists are the experts in the medical imaging and radiation therapy departments, and therefore it is the responsibility of radiologic technologists to ensure that all radiation safety policies and procedures are closely followed so that quality imaging can be performed and patient dose and occupational radiation exposure can be kept as low as reasonably achievable.